speaker as part of our IHCC educational webinar series, and we're grateful to have our speaker with us today to talk about this subject. So about this presentation explores the evolving landscape of genetic testing in Israel, highlighting the utility and diagnostic yield of various approaches. We'll examine how technological advances have reshaped clinical practice and impacted the unique genetic profile of the Israeli population. So let me tell you a little bit about our speaker today. So Dr. Rakefet Chen-Shtoyerman is a geneticist specializing in medical and hereditary cancer genomics. She earned her Ph.D. from Tel Aviv University, focusing on the genetic basis of colorectal cancer in the Israeli population. With extensive experience in clinical research and genetic counseling, she has contributed to national and international consortiums on BRCA mutations and gastrointestinal hereditary tumors. She is an active faculty member at Ariel University, teaching courses in genetics, oncogenetics, and medical genomics. So with that introduction, I want to also share that we will have time at the end of the presentation for questions. If during Ricky's presentation you have a question, you can capture that in the chat, and we will certainly review the chat for questions towards the end of the presentation. But if you have a question that you want to get share directly at the end of the presentation, we'll do those too. So with that, Ricky, we'll turn it over to you.
Thank you, and good morning to everybody on the U.S. Time zone, and good afternoon if there's anybody here on the Middle Eastern time zone. Thank you, Grant, for the warm introduction, and Scott. And I hope you enjoy this. It's going to be quite swift. I don't know exactly who the audience is, except for Talia Donenberg, a good friend and colleague, for being here. So the rest of you, if I'm not being understood or you want to clarify something along the way, that's fine with me. Otherwise, I imagine it's going to be quite swift. And I hope you hear me well and see everything. So here we go. So I'm going to talk about genetic counseling and cancer genetic counseling in general, and the technological milestones and how we adapted them in Israel, with some unique aspects to our population and our health system. So the history of genetic counseling is almost as old, or the history of cancer genetic counseling is almost as old as genetic counseling in general, but traditionally genetic counseling started off with sick children and pregnancy or prenatal care, and sort of cancer genetics came on later. So back in the days when we recognized hereditary cancer syndromes, there were limited tools for genetic analysis, and the recognition of syndromes is actually even earlier than the 20th century. It goes back even to the 19th century, but we're not going to go so much back in history. The first steps in molecular genetics of cancer is Knudson's two-hit hypothesis. And we started doing pedigrees to analyze and assess familial risk somewhere in the 70s, and to develop the practice of medical genetics. So the actual revolution in my eyes, or in the Israeli, that are relevant to Israel, is mainly the discovery of the BRCA genes in the mid-90s. And shortly after that, it was discovered that the Jewish Ashkenazi population carries a very high frequency of 3 common mutations, 2 of which you can see here. And that really kicked off the services and the testing in my country. So something about Israel's population, just as a tip, we're close to 10 million, 8 million Jews, and close to 2 million Arabs. And the Jewish population is about half Jewish Ashkenazi, and the rest of various ethnicities depending on the historical country of origin. And when we understand that special composite, we can tailor specific genetic testing to those specific populations in the clinical setting. So we started off with testing the Ashkenazi mutations in Ashkenazi breast cancer patients, but there are a lot of breast cancer patients that are non-Ashkenazi or not Jews, and what did we do with them? And we either did not test them, or we did a lot of irrelevant testing. And that, of course, caused a lot of disparity and situations where women of the irrelevant descents got negative test results, not because they were not sick due to genetic causes, but just because it was proven that they were not Ashkenazi. So a lot of misconceptions, not just amongst patients, but also amongst professionals. And we're only recently, I would say, shedding or letting go of past mistakes, because people would walk away thinking that they are negative for a genetic causing a mutation. So back at the beginning of the 2000s, I would say we started, sequencing became more abundant. It was very expensive, around $1,000 per gene. And it takes a lot of time. It takes a few months to receive a result. But yet again, we could offer something to the relevant patients. And another problem of these sequencing results is that we were getting a lot of vusses. That's a Yiddish term. I'm kidding. It's a term that we will clarify soon. But this is a slide I share with patients to clarify a point that when they have mutation testing, then they're being tested for one letter or one nucleotide. And when they're having their gene sequenced, they're having like the whole book of Genesis sequenced. And when they're having two genes, it's two books in the Bible and so forth. And this is an analogy they can relate to, and they understand the differences between the genetic tests that are offered. It's always hard to communicate information like this with patients. So I use this slide quite commonly. So when we started sequencing, we started receiving a lot of variants of uncertain significance, these results that are hard to interpret. And then we have to go to mutation databases or do controlled ethnic match population tests to find out if these are just common variants or pathogenic mutations, or do segregation analysis in the family, and go to models and search for conservation within species and other technologies that are not commonly available or when you have to deliver a result to a patient. And of course, as time goes and we know and we map these populations, the rates of variants of uncertain significance has significantly dropped. But as we sequenced more and more patients that were non-Ashkenazi, we of course discovered many more mutations which were common in other groups, such as Jewish Yemenites, Jewish Sephardics, like from the Balkans, Arab mutations, and so forth. So more mutations in more subgroups. We don't always define them as founder. A founder mutation is a mutation that is at a high frequency, a rare allele, usually on the basis of a common haplotype. and leading to a higher than expected rate of rare Mendelian conditions. So these other mutations we may more define as recurrent or common, but it doesn't matter because we immediately can utilize them in genetic practice. So when we do so, we can reach a relative nice rate of detection. And if we don't detect a common mutation and we highly suspect a genetic background, we can go on and do the sequencing. Sequencing has served to be relatively with a low utility rate, only around 3.3%. And this is the time to say that I want to thank all the people I will be presenting their works and not, I will not mention names or giving out credits, but there are a lot of people that their works will be presented from Israel and from the world. So what do we do beyond sequencing? And of course, this is the era when we know that there are a lot of cancer susceptibility genes, specifically for breast cancer. And you can see some of the highlighted ones here beyond BRCA1, 2, PALB2, ATM, and so forth. So when we don't, or all the patients we used to sequence for BRCA1 and BRCA2, we can now sequence for a whole lot of genes at once. And you can see the genes that confer a very high risk to cancer are relatively rare. There's a larger group of genes that are considered as moderate risk genes that are relatively more abundant if we look at the frequencies. And there's a whole lot of other SNPs or single nucleotide variants in different genes that each one of its own confers only a small risk for cancer, but together we can group them and use them as a test that is called a polygenic risk scores, which is, by the way, not offered in Israel as of yet, and it's probably where we're going. As this profession of ours grew and the expertise and the technicals, there were also models that were developed to help us assess in the clinic which family or which patient is at a high risk or at a high chance for having a mutation. And those people who have a chance of more than 10% are reimbursed by the country, by the National Health Program. And they're eligible for testing at no cost, even though the tests of today, which I'm referring to, is of course the gene panels. Based on next generation sequencing technologies, these tests today are at around $250. And again, they don't have to be paid out of pocket if you have a high chance of being a carrier. So that brought us into the age of the panels. This is one of the common panels, and in red you have some breast cancer genes, these are the Lynch's and so forth. Other things that affected our work on the way, everybody knows the Angelina Jolie effect. Her publication around 2013 regarding her carrier status has caused a global effect. I think it's even got a medical term after her. And back in the times, we had faxes, and our faxes were just working, you know, without stopping, and we would get referrals for asking for genetic counseling endlessly. This is a slide I borrowed from a dear colleague in Holland named Fred Menko. I think he's still the editor of Familial Cancer. And this slide changed my personal career because what it does is only show, it's in Dutch, but I'll give you the highlights. I don't speak Dutch, of course. It gives a total number of referrals between 2000 and 2005 in Holland. And the yellow is just general referrals, and the part in purplish or blue is the referral due to cancer genetics, and that has changed in 5 years from 4,000 to 7,500 approximately. And this slide convinced my boss in the Genetic Institute, who was a classic geneticist in Israel because he's an OBGYN by training, and his world is the prenatal world. And it was not trivial to become a person dealing only with cancer genetics. And I was one of the very, I think, first two genetic counselors in Israel to be doing oncogenetics or cancer genetics as a full-time profession. And that's very normal and very common throughout the world, and now also in Israel. But I am a dinosaur, so I have that perspective of time, so wanted to share that with you. So another program we designed to cope with the endless amounts of work is to have a direct referral program, which means that doctors in our institute can send tests directly to the lab without genetic counseling. And that worked great, very successful. Of course, it's always, the pitfall is always bureaucracy. Bureaucracy is a big thing in Israel. I think it's a big thing everywhere. In the US, you call it billing or insurance. And here it's the health basket and what is in the basket and what is out of basket and out of pocket, so forth. And the place where it falls or it doesn't work is the patient needs a special permit to do the test. And instead of sending the test directly and then us charging the HMO directly, they have to come up with a piece of paper, and that sometimes is when they say, "Oh, I'll have the genetic counselor do that work. I don't have the time to deal with it. I'm running to the surgery room." So we still have a lot to work on, and it's sad to say, but it's a lot in the small details. Another thing I wanted to share with you is our success, or I hope the beginning of a success story with the Jewish Ethiopian population. There were two major operations in the 80s and 90s, and I remind you, those were times of famine or hunger in Ethiopia. And this population was brought to Israel. Today, it consists of about 120,000 living in Israel. And in the past few years, we have noted 3 different mutations in BRCA2 in 11 families. And this is work that we've combined forces from 6 hospitals. And then we went further and tested these 3 mutations at a control population from the same descent, only to find out that there's actually a very high rate of carrier. And if you know the numbers, and you may not know, so I'll state them, of the carrier frequency in the Jewish Ashkenazi healthy population is about 2.5%. It took us 30 years from the discovery of the genes BRCA1 and 2 and 3 common Ashkenazi mutations in the 90s to start a screening program for healthy Ashkenazi women in 2000, just at the time of Corona. And with the Ethiopian population, when we published this in 2022, and just a few months ago, it has become a national screening program, meaning every woman over 18, I don't think it should be 18, but nevertheless, this is a decision of the Israeli Health Ministry. Every woman is eligible to do the test for the common Ethiopian mutations, and we hope it kicks off successfully. the young women of this population. And of course, these families start off as heartbreaking cases of advanced or metastatic breast cancer in very young women. But they tell me that people are speaking of me in their Facebook groups, which is really nice because we're having a really hard time with the older population. And these young women are going to be the key to the success of this program. And right now, only in my institution, we have 5,000 tests a year as part of the National Ashkenazi Screening Program. And it'll be very interesting to see what the numbers of Ethiopian women that we are getting into, that we'll get into during this year. So I'm really, it's nice to make an impact, not just to have a scientific publication. And it's nice that in this case, it happened rather fast. Switching to colorectal cancer, my favorites, and you can see that there's a great portion that is considered familial or hereditary. And I will talk a little bit about Lynch syndrome, formerly HNPCC. And you can see the famous Henry Lynch, who was deceased, and his son Patrick Lynch, all were part of this important group that's actively globally. And I'll just share a little bit of our work that was presented in the European Society of Hereditary Cancers. So HNPCC, later called Lynch syndrome, is the most common form of hereditary colorectal and endometrial cancer, with a global frequency of around 1 in 300. It's due to germline, to mutations that are hereditary in one of 4 genes, also called the mismatch repair genes. And there are diagnostic and screening criteria that have been postulated in the 90s. I won't go in detail, but those are clinical or screening criteria. And the main 2 technologies used to screen for Lynch syndrome are done on tumor testing. One is MSI, the other is immunohistochemistry. And when we stain these tumors in Lynch syndrome, this is a positive stain, meaning the expression of the protein is normal. And in this slide, you can see a tumor that is deficient of the staining for MSH2, whereas the normal mucosa stains positive. So this situation is suggestive of a Lynch syndrome patient, and then we have to continue on and do the germline or the DNA, the blood test working, and find the mutation. So very early on, when I started, I think one of the first works in Israel in Lynch syndrome, we discovered 2 common founder mutations, one in the Georgian population, the other one in the Jewish Ashkenazis, and later in Israeli Arabs. And the big success of our working group in Israel is that we have managed to have the universal immunohistochemistry on tumors begin about 10 years ago. For cases that are under 70, either colon or endometrial. And once there's negative staining, it goes on to genetic counseling, and then a 2-step process of trying to find a mutation, either through the common mutation panel, which I'll talk about, or the NGS, the multi-gene cancer panel. So I just want to commemorate Robert Hofstra in Holland, his lab in Groningen. Robert has died of brain cancer, but in his lab, it was that the 2 first Jewish founder mutations were detected. So today, as of now, there are about 14 mutations that are common in Israel. In my cohort, in my hospital and the adjacent hospital, we have reached a total of 175 carriers. And you can see the various ethnicities among the non-Ashkenazi Jews, Georgian, Persian, Balkan, and so forth. And we wanted to see how many of our families have private mutations and how many the mutations are due to the founder or the known mutations. So about more than half of our cohort in total, and it changes by gene, I'm not going to go into detail, will have a private mutation. Thus, we will need the full panel and not just doing the common mutations. So right now, we're testing for mutations that we have found in more than one family, and to see if these mutations will find their way into the already known list of mutations that we have as of today. So I hope we'll have those results real soon. One thing very important to stratify as a genetic counselor is how are we doing with cascade testing, meaning how good or how bad are we at reaching out to other healthy individuals in the family, and we're doing pretty lousy. And what you can see here is the number of families in which only one individual has been tested in addition to the index case, and that's half of the families. And this great family where we reached 14 individuals is actually an ultra-Orthodox family that was very easy to have them all come in. And I don't feel there is any invasion of privacy. If you can tell them apart, then you're really good at it. But this was at Koana with a special atir. But the father who lost his wife to lynch had all the sons and daughters, I think there were 10 or 12 come in, and then the third generation come in for testing. So they were very cooperative, but most families, we don't get such good cooperation, or we don't do so good on the information on our side, certainly an area to improve. So generally, if we summarize what's going on in Israel, is that we have a two-tier genetic workup. The first is doing common mutations, and the second, if that comes out negative, is do a multi-cancer gene panel. And these are the common 51 mutations are organized by gene. And again, the diagnostic yield of targeted founder mutations is not so good, according to Beilinson, a big center working out of Israel. So it's always a consideration. Are we wasting time? Should we go to the panels as a first stage? And the last point I want to make is that maybe we should offer just, you do universal panels for cancer patients, skip the whole tumor testing and lynch, and any cancer patient should do just a comprehensive multi-gene panel, since it's so cheap and now available. And some international work coming out of the US generally has proven that we will find, for instance, a 1.3% carrier rate for Lynch syndrome when we do this with under no guidelines, meaning that more than half of patients that have a positive result would have been missed if they had gone testing according to guidelines, for instance, the NCCN guidelines. So if we stick to guidelines, we are going to miss a lot of patients. 1 in 8 have a clinically actionable genetic finding, many of these not meeting current testing criteria. So the world is shifting towards that. The HMOs less, but they hopefully will get there. And of course, it raises a lot of questions as to how many genes we should sequence, what genes exactly. Are we understanding the results sufficiently to guide intervention in medical management? We're arguing on the ATM, check 2, and all those medium or the genes that are not, I'm missing the word, but I talked about it, the moderate penetrance genes. So we still don't have good enough guidelines to intervene. So should we test for them? And of course, the utility, and also what is the threshold to test for? Should it be any cancer patient? And are we causing distress, or are we really helping people? Those are always questions that this raises. And I think this is almost the last, or getting close to the last slides. But when we're visioning precision medicine, of course, we're using technologies. If once it was so expensive just to test for one mutation, and right now it's so cheap to test for multiple genes altogether, and the prices have gone down within the years. Maybe we're reaching a state where we can offer cancer gene panels as screening for healthy individuals. Okay. So there are people advocating for that. Of course, I don't see national programs offering that as with no payment, but certainly I can see a lot of companies coming out and offering this, and insurance or life insurance companies are starting to offer programs like this, not so common, not as part of the health, the public's health system, but as a vision, we are probably going there, because our vision is that if we know someone is at risk, we have interventions, we have screening programs, and maybe soon we will even have vaccines that we can take people with Lynch syndrome and give them something, vaccinate them so they won't get cancer. This is amazing, and this is part of this is already happening. So this is where we're going, and Israel is just behind the big world, but I think we're getting there. And the roles of genetic counselors are always to assess the risk, to educate, to interpret results, to give a little psychosocial supports, and to try and integrate all this knowledge into multidisciplinary teams. And I can tell you that one of the problems in Israel, I didn't go into this, but we're detecting a lot of carriers in these national programs. And the carrier clinic in my hospital shut down. They're not taking in any new carriers for follow-up. And that's very sad, but they are over, they just can't handle the numbers. So as a genetic counselor, it's pretty awful to say to a woman, well, you are a BRCA carrier, you will have to do MRI, you will have to be tested by a breast surgeon twice a year and the OBGYN and so forth. And you have this list of numbers, and you can try and calling these clinics and finding out where you have available appointments, because you can't go upstairs as we did a year or 2 years ago, because we just don't have the personnel to deal with it. So that's part of our disparities. Of course, we have to the challenges of variance and access, and we need to know more about these moderate risk genes and alleles. And we always are looking at the next stage. I think there's a lot more going on in the US in terms of somatic testing, and that's part of the era and the part of the results that we have to interpret today as genetic counselors. We will be, there will be PRSs entering the clinics. And of course, whole exomes, whole genomes is just right around the corner, along with AI and mainstreaming it with oncology. So in general, I think I gave you a real bird's eye view of how we've moved on from points or founder mutations to sequencing our tumor testing, and how we're slowly shifting towards a pan-ethnic sort of attitude, with panel testing being the first thing we do. We're not nearly there. And a lot more genetic counselors that are being trained and specifically working in cancer genetics. There is no genetic counselor working in an oncology as part of the oncology team. There are oncologist doctors who are at least there is one of this sort in Israel. And she's an oncologist who was trained in genetics also. And I'm sure we'll have more people like that. And that's going to be wonderful. And I promised myself that during this time, every lecture of mine will bring to mind my two cousins who have died. Tzachi, who was murdered in Gaza, his daughter murdered in his arms before he was taken while trying to hold the safe room. Guy, the other cousin who died a year later in Lebanon, who was killed. And together with Tzachi, Omri was taken hostage in Gaza. This was the last sign of life. There are 59 hostages in Gaza. More than half are considered or thought to be alive. Omri is one of them. 559 days. We're praying for their return. We are praying and hoping to cease all violence in the area. I don't know who the audience is, but I'm sure that identifying high-risk families always starts with us, always starts with you. And the importance of that is immense. Knowledge is power, as you know, and you're welcome to reach out with questions and emails following this lecture. I really want to thank you for listening up. And I think I even made it on time, Grant.
Yes, you did a fabulous job. Thank you so much, Ricky. A great presentation. I certainly learned a lot. I've written down several questions of my own, but I first want to open it up to anybody that's has a question they might want to start with.
Here.
Like I said, I have quite a few questions, and I'll be somewhat selfish and so sort of treat you as my personal professor here to teach me. So I'll jump in, and you'll see that Ricky, my questions are not going to be from the scientific or medical side. That's not my background, but from the healthcare delivery side. And I'll start with some basic questions around genetic counseling. I know that this has been a big topic in a lot of conversations that we have talked with GGMC members and other healthcare professionals around the world. Everybody's trying to say, how can we develop a better, stronger genetic counseling program? Can you give us a quick review of how genetic counselors are produced in Israel? Are there
Mhm.
strong programs on the university level, and is there like a demand or maybe a government program that's trying to generate more genetic counselors?
Excellent question. I think people will suspect I asked you to ask for it because I really wanted to talk about it and did not have the time. So again, I'll start from my point of view. I am the Lynch syndrome was coined in 1966. That is my year of birth, so you know how old I am. So when I was growing up professionally, there was no program in Israel. I was accepted to the famous Sarah Lawrence program in New York. And, and then I fell in love and moved to a kibbutz in the south of Israel and did not go to New York. I also was sparing my folks with the huge amount of money. They were already sending my brother off to study at the Berklee School of Jazz in Boston. So that's a lot of money in Israeli terms. But besides the personal story, when I came back from the States after my husband's postdoc, there was already one program in place at the Hebrew University. Today, there are 3 active programs. Each of these programs opens up to a very high selective group of students, and they open up every 2 years. And just a few years ago, a company, which I won't say the name, has opened its doors to genetic counselors and sort of wiped half of the, or not half, but just a lot of genetic counselors that just came out from the oven and just finished their, their training times at the institutes, shifted over to the industry, and that was a first in Israel. We had very few jobs in the industry up until then, not like the US. So that I think will cause, or I think the programs will have to change the numbers that they're accepting now. And I think there are more programs waiting to be opened that are waiting for government approvals, higher education approvals, because the numbers are, in the beginning, we didn't want to have a lot of people, and people were worried about their jobs being taken. Now I think that's not the case. So there's a great need for genetic counselors everywhere and in Israel.
So does the Israeli population, how aware are they about genetic counseling? When they start seeking medical care, are they aware that there's this option? Do they ask about it?
Yes, there are, first of all, from the prenatal side and the carrier screening, it's very developed, and there are national programs evolving. So the younger population certainly, and the oncologists today don't go. They're very aware of the need of genetic counseling for many cases. So that's not the issue. The problem is always on our side, not enough of us, and not being able to supply everybody with the correct services. And I'm all for teaching all the professionals to do more testing on their own. I don't think I need to see every breast cancer patient. Only those with a positive result, only those that had negative result and need to do more extensive testing. So we should be doing a lot better in educating our fellow colleagues, in the other departments. I think it should be in that sense. I let go. I'm not an old-fashioned, the older generation of geneticists were very afraid to let other professionals do genetic testing. Nowadays, we're just hoping that the pediatricians will do chromosomal microarrays on their own for every child with autism or developmental disorders, and we're really promoting that. We can't handle everybody, so we're too aware.
So if you're talking about clinicians ordering the majority of the tests, are are there tools that are available to them to help them with the interpretation of those tests and then help them decide, what treatments that they want to order for their patients based on the result of those tests?
I think not enough, certainly not tools, but the communication is direct, and we do have departmental meetings. So in case they don't know nothing, I think they know enough to ask. But there are problems of, especially with the variants of uncertain significance. The woman will go out and she said, well, I have a mutation. I want you to operate on my ovaries. And that's the area where you have to be really careful and make sure that that the doctor directly sees the report, because maybe the woman did not understand correctly what she has. That area is always a gray area. So that's where it's a little more dangerous, but usually they know how to reach out to us. And there's a little more that's done in terms of educating other professions in the field of bioinformatics. But I'm telling you, even as geneticists, we struggle with all of the bioinformatics that we have to do. So expecting it from your standard OBGYN or a surgeon, I think is not real. I don't think there are tools to automate this as of now. That's a good point.
So you had slides that shared some really successful research in finding mutations in other populations. You talked about how you started with the Ashkenazi populations, but then expanded beyond that and found other mutations in those populations too. So there's this question of if we talk about how we translate those type of discoveries from research into clinical care, can you talk about how that process happens in Israel?
Yes, I didn't emphasize enough on that part, but the way things are done here is two parallel lines. One line is the Medical Doctors Association. So when we find something that's common and we think it should be offered to a population, there are meetings by the Israeli Medical Doctors Associations. Unfortunately, genetic counselors are not, we're a part of that, but we don't have a voting right. We can present data, we can talk, we can discuss, we're not allowed to vote, but we usually work together as a team despite that difference. And we come out with position statements like you're very much familiar with from Europe and the US. With those statements, there are recommendations to the health basket, as we said, to the Israeli health ministry to create the funding and the recommendation and the decision to move on with that, together with the pharma industry. So, when you have a kit that's being specifically designed to test for 51 mutations, it hits off pretty quickly. For instance, now we have the 51 mutation kit. It does not include the Ethiopian mutations, and they're working on a new kit, even though it's applicable only to a small part of the testing that will come in. But it's easier for the lab to, throw everybody in on the same kit. So, and it's worthwhile for them to develop this. So this happens sort of in parallel.
So there is obviously from what you just shared, there is a translational program that seems to be at least starting to work.
Yep.
Yeah, okay, great.
Yes, yes, yes. Absolutely.
I'm gonna I'm gonna be even just a little bit more selfish and ask my next question based on my a personal family experience.
Okay.
I had a sister-in-law who had a severe family history of breast ovarian cancer. Her grandmother passed away in her 40s, breast ovarian. Her mother passed away in her late 30s of the same. And then so she went and got testing, and it was just, I think it was just the BRCA 1 and 2 tests, and came away negative.
Mhm.
But she herself passed away uh, of breast cancer too. So the reason why I'm asking this question is, a lot of the public, when they think about breast cancer risk, they just think about the BRCA 1 and 2 genes. And you had slides that talked about there's so many other genes that could contribute, and it's really has complicated the answer. How do we make that determination by using genetic testing as to really establishing the risk for a patient? And you talked about, developing a polygenic risk score. And you did mention that wasn't like either fully developed or quite fully used in the clinic. Can you expand on the state of that in the future of that?
Okay, so PRSs as they're being called now, and first I want to just say something about your personal story. We have a lot of cases where the family history is very indicative, and we don't find anything, even if they go beyond BRCA 1 and 2 and do panel. And for something, we call it the missing heritability, and it can always be somewhere either deeper in the introns or methylation of the gene.
Mm,
Or so the answer is out there, is just depending on how much technology you're going to use. And we're still not going to find everything with what we have in the clinic as of today. How many of you know polygenic risk scores are going to enter the clinic? I think for everything, for heart conditions, for cancer, for cholesterol, for lots of other common multifactorial conditions. And they're not going to explain, I think, those dramatic families with very early onset. But they are going to help stratify risk among populations. If you want to take like the general population, do mammograms beginning age 50, but some people that have a high PRS may have to start at the age of 40. So that's going to affect health. I know that my organization, Clalit, is planning to implement these PRSs for a lot of conditions, but that'll be in the next 5 or 10 years. If you talk to Mark Tishkowitz, Antonionis, the people from Cambridge, NHS, they have models that are now taking into account the genetic basis, like what we have from panels, the family history, your life habits, how much you drink, how many kids you've had, so forth, and a PRS score, which will be a sort of DNA test that is done in addition to the panel, and sort of put all of that into a mathematical algorithm that will give an output of your risk. And you will be classified as group A, B, or C, and have your specific program for surveillance according to that risk, which is comprised of a lot of details. But right now we're basically working either general population, family history as its own, and genetic or high risk alleles.
mhm.
That's where we're at least in Israel. We're not into, we haven't incorporated lifestyle or PRSs into our practice, and it'll happen. I'm sure companies will push it forward as the new test to tell you if you'll have cancer. Those are popular tests, along with the liquid biopsies and what have you coming into the market. So we'll get a lot of that.
Well, oh, great, Ricky. Thank you again so much for this presentation. A lot of information shared. I found it absolutely fascinating. And in fact, you had your second to your last slide that was talking about what the future holds. And I think there's a whole presentation we could do just on that slide by itself. Thank you, everybody, for joining us. I will let Scott, I think, talk about quickly our next presentation for next month, and then we will then say good day to everybody.
Thank you so much for having me.
Thank you, Ricky. And I would just like to let everyone know that our next monthly webinar is approximately a month from today on the 22nd of May. And that's 10 a.m. Eastern Daylight Savings Time. Our speaker is Dr. Peter Wirtz. He's the Chief Scientific Officer at Nightingale Health. Nightingale is a metabolomics assay company, and the title of his talk will be Urine Metabolite Biomarkers in Large Cohorts, Biological Insights in General Population Settings and Parallels to the Translations of Blood Metabolomics. Please join us if you're interested. Thank you.
All right. Thanks, everybody.
Thanks, everyone. Bye-bye.
Bye.